Assalamualaikum, I'm Dr. Shan, and we are going to discuss surgical management of urinary incontinence according to European Association of Urology. The content of today's presentation includes the introduction, and then we'll discuss the surgical options for women with uncomplicated stress urinary incontinence, women with complicated stress urinary incontinence, urinary incontinence associated with genitourinary prolapse, then stress urinary incontinence in men, and incontinence with refractory detrusor-overactivity and lower compliance of the bladders. And then mixed incontinence surgical options and incontinence surgical options for fertility. And then we have some flow charts for it to summarize today's topic. To better understand and EUA categorized the patient into four or five categories, which included women with uncomplicated stress urinary incontinence. In this, though patient has no history of previous surgery, no neogenic low urinary tract dysfunction, and no bothersome genitourinary prolapse, and woman is not considering further pregnancy. The second category includes the woman with complicated stress urinary incontinence. It includes all the previous, such as having previous surgery and a neurogenic low urinary tract dysfunction or a prolapse. Then they categorize a separate category for associated genitourinary prolapse. But in this, they discuss only the incontinence part, but there is no comment on the treatment of prolapse itself. And then the next category is men with stress urinary incontinence, mainly men with post-prostatectomy incontinence without neurological disease affecting the lower urinary tract, and the patient with refractory detrusor-overactivity. These are the parameters which are considered as an outcome of the surgery, which includes a decrease in the continence rate and the number of incontinence episodes. Patient reported outcome is general and procedure specific complications, generic specific and correlated quality of life, which includes sexual and bowel health. In the first category, the women with uncomplicated stress incontinence. These are the surgical options available, such as abdominal approaches, which can be open and laparoscopic, and the procedures such as retropelvic Colposuspension, and these are the two techniques, Birch and Marshall. And then the other is contemporary, which includes vaginal sling, tension-free vaginal tape, and transobturator tape. The third option is bulking agents. These are the types of slings used in surgical management of stress urinary incontinence. First one is the retropelvic mid-urethral sling. It is a mesh sling placed between the mid-urethra with arms extending behind the pelvic bone, as seen in the picture. And the second one is the transobturator mid-urethral sling. The mesh sling placed between the mid-urethra with arms through the obturator format. And the third one is the single incision mid-urethral sling, mesh placed between the mid-urethra with palms to the obturator format. The autologous facial or vaginal sling, facial sling placed beneath the urethra at the level of bladder neck with arms or suture passing behind the pelvic bone. The mid-urethral slings, early clinical studies identified that non-autologous slings should be made from monofilament, non-absorbable material, typically propylene, and constructed as 1 to 2 cm wide mesh with a relatively large pore size, that is micropores. Mid-uterus slings are now the most frequently used surgical intervention in Europe for women with stress urinary incontinence. And the summary of evidence for mid-uterus slings. The retropubic mid-uterus sling provides equivalent patient-reported subjective and objective care and with stress urinary incontinence compared with Colposuspension. Mid-uterine synthetic slings inserted by either trans-obturator or retropubic route provide equivalent patient-reported outcome at 5 years. Mid-uterus synthetic sling inserted at the retropubic route has higher objective patient-reported care at 8 years. The long-term analysis of mid-uterus sling cohorts showed a sustained response beyond 10 years. And the retropubic route of insertion is associated with higher intraoperative risk of bladder perforation and higher rate of voiding dysfunction than the trans-obturator route. The trans-obturator route of insertion is associated with a higher risk of groin pain than the retropubic pain. The long-term analysis showed no difference in terms of efficacy for the skin to vagina compared to vagina to skin direction up to 9 years. The top to bottom direction in the retropubic approach is associated with a higher risk of post-operative voiding dysfunction. Adjustable mid-uterine synthetic sling devices may be effective for cure or improvement of stress urinary incontinence in women. There is no evidence that adjustable slings are superior to standard mid-uterine slings. And the comparative efficacy of single incision slings against conventional mid-uterine sling is uncertain. Operation time for insertion of single incision mid-uterine slings are shorter than for standard retropubic slings. Blood loss and immediate post-operative pain are lower for insertion of single incision slings compared with conventional mid-uterine slings. There is no evidence that other adverse outcomes from surgery are more or less likely with single incision slings than the conventional mid-uterine slings. Incontinence surgery has similar outcomes in older patients, that is more than 60 years of age. The risk for failure from surgical repair of stress urinary incontinence or suffering adverse events appears to increase with age. There is no evidence that any surgical procedure has greater efficacy or safety in older women than another procedure. Incontinence surgery may be safely performed in obese women, however, outcomes may be inferior. In women undergoing surgery for stress urinary incontinence, coital incontinence is likely to improve. Overall sexual function is likely to deteriorate following stress urinary incontinence surgery. Improvement in sexual life is higher with single incision slings than with the standard mid-uterine slings. After mid-uterine slings, another option is open and laparoscopic surgery for stress urinary incontinence, in which autologous facial sling is more effective than Colposuspension for the improvement of surgical stress urinary incontinence. Autologous facial sling has a higher risk of operative complications than open Colposuspension, particularly voiding dysfunction and post-operative urinary tract infection. And Colposuspension is associated with higher long-term risk for and then the mid-uterine slings. Laparoscopic Colposuspension has a shorter hospital stay and may be more cost-effective than open Colposuspension.
No, POP stands for, I think, post-operative prolapse.
Yes, sir. So, post-operative prolapse.
Right.
Bulking agents. The periuterine injection of bulking agent may provide short-term improvement and cure in women with stress urinary incontinence. Bulking agents are less effective than corposuspension or autologous sling for cure of stress urinary incontinence. Autologous fat and hyaluronic acid as bulking agents have a higher risk of adverse effects. Adverse effects rates are lower compared to open surgery. There is no evidence that one type of bulking agent is better than another type. The periurethral route of injection of bulking agent may be associated with a higher risk of urinary retention compared to transurethral route. The recommendation for women with uncomplicated stress urinary incontinence it is strongly recommended that offer a mid-urethral sling to women with complicated stress urinary incontinence. Inform women of the unique complication associated with each individual procedure. Inform women who are being offered a single incision sling that long-term efficacy remains uncertain. Inform women undergoing Colposuspension that there is a longer duration of surgery, hospital stay and recovery, as well as a high risk of development of pelvic organ prolapse and voiding dysfunction post-bleeding. Inform older women with stress urinary incontinence about the increased risk associated with surgery, including the lower probability of success. Inform women that any vaginal surgery may have impact on sexual function, which is generally positive. Only offer new devices for which there is no level 1 evidence base as part of structured research program. Only offer a digestible mid-urethral sling as a primary surgical treatment for stress urinary incontinence as a part of structured research program. Offer bulking agents to women with stress urinary incontinence who request a low-risk procedure with understanding that repeat injections are likely and long-term durability is not established. Now we'll discuss the complicated stress urinary incontinence in women. This section addresses the surgical treatment for women who have had previous surgery for stress urinary incontinence which has failed, or those women who have undergone previous radiotherapy affecting the vagina and the uterus tissues. Neurogenic lower uterine tract dysfunction is reviewed by EUA guidelines on urology. The surgical interventions options for these categories of patients are Colposuspension or sling following failed surgery and external compression devices. The Colposuspension or sling following failed surgery, there is conflicting evidence whether prior surgery for stress urinary incontinence or prolapse results in inferior outcomes from repeat operations or for stress urinary incontinence. Most procedures will be less effective when used as second-line procedure. In women who have had more than 2 procedures for stress urinary incontinence, the results of open Colposuspension are inferior to autologous facial sling. Tension-free vaginal tape and have similar outcomes in patients with recurrent stress urinary incontinence. Reverse Colposuspension has similar patient-reported or objective cure rates when compared to transvaginal tape. External compression devices. Summary for evidence includes implantation of an artificial sphincter can improve or cure incontinence in women with stress urinary incontinence caused by sphincter insufficiency. Implantation of adjustable compression therapy such as ACT device may improve complicated urinary incontinence. Complications includes mechanical failure and device explantation often occur with both the artificial sphincter and the adjustable compression therapy. Explantation is more frequent in older women and among those who have had previous Colposuspension or pelvic radiotherapy. The recommendation includes the management of complicated stress urinary incontinence should only be offered in expert centers. The choice of surgery for recurrent stress urinary incontinence should be based on careful evaluation of the individual patient, including multi-channel urodynamics and imaging as appropriate. Inform women with recurrent stress urinary incontinence that the outcome of surgical procedure when used as a second-line treatment is generally inferior to its use as a first-line treatment, both in terms of reduced efficacy and increased risk of complications. Consider secondary synthetic sling, Colposuspension, and autologous sling as the first options for women with complicated stress urinary incontinence. Inform women receiving artificial urinary sphincter or adjustable compression device that although cure is possible, even in expert center there is a risk of complications which includes mechanical failure and need for explantation.
And you see, the exciting thing, or just a coincidence as regards artificial sphincter, is a group of scientists who were actually developing this device, once they move on to their experiments, thought of that there is the same mechanism behind providing an artificial sphincter as well as providing a device for erectile dysfunction. So it is rather interesting that both these devices, one for impotency, that is erectile dysfunction, and the other for artificial sphincter, they work on the same principle, and perhaps they have got a same kind of a design, slightly different from both these aspects, but they have got the same principle of inflation and deflation, and they are actually developed by the same group of people who were actually developing it for one purpose, and then it was used for both the purposes. So this is something which is interesting. Yes, please.
Now we will discuss the women with pelvic organ prolapse and stress urinary incontinence. There is a clear association between the presence of pelvic organ prolapse and stress urinary incontinence. Although the subject of prolapse is not part of the remit of these guidelines, the extent to which it impacts on the management of stress urinary incontinence will be addressed. The aim is to assess the options available to women who require surgery for pelvic organ prolapse and who have associated urinary incontinence, either symptomatic or after detection of prolapse, and to assess the value of prophylactic and anti-incontinence surgery in women with no evidence of urinary incontinence. It is further characterized women with pelvic organ prolapse and urinary incontinence. Surgery for pelvic organ prolapse plus stress urinary incontinence shows a higher rate of cure for urinary incontinence in short term than pelvic organ prolapse surgery alone. There is conflicting evidence on relative long-term benefit of surgery for pelvic organ prolapse and stress urinary incontinence versus pelvic organ prolapse surgery alone. Combined surgery for pelvic organ prolapse plus stress urinary incontinence carries a higher risk of adverse effect events than pelvic organ prolapse or surgery alone. Continent women with pelvic organ prolapse. They are at risk of developing urinary incontinence post-operatively. The addition of prophylactic anti-incontinence procedure reduces the risk of post-operative urinary incontinence. The addition of prophylactic anti-incontinence procedure increases the risk of adverse effects too. Women with pelvic organ prolapse and overactive bladder. There is some low-level inconsistent evidence to suggest that surgical repair of pelvic organ prolapse can improve symptoms of overactive bladder. The recommendation for pelvic organ prolapse and stress urinary incontinence are offer for simultaneous surgery for pelvic organ prolapse and stress urinary incontinence, it is strongly recommended. Inform women of the increased risk of adverse events with combined surgery compared to prolapse surgery alone. Recommendation for women requiring surgery for bothersome pelvic organ prolapse who do not have symptomatic or unmasked stress urinary incontinence. Inform women that there is a risk of developing de novo stress urinary incontinence after prolapse surgery. Warn women that the benefit of surgery for stress urinary incontinence may be outweighed by the increased risk of adverse events with combined surgery compared to prolapse surgery alone. Urethral diverticulum. A female urethral diverticulum is a sac-like protrusion made by the entire urethral wall or only by the urethral mucosa situated between the periurethral tissues and the anterior vaginal wall. Urethral diverticula give rise to a variety of symptoms that include pain, urgency, frequency, recurrent UTIs, vaginal discharge, dyspareunia, and voiding difficulties or urinary incontinence. MRI has good sensitivity and specificity for the diagnosis of urethral diverticula. However, there is risk of misdiagnosis and missing potential intralumen neoplastic change. Surgical removal of symptomatic urethral diverticula provides good long-term results. However, women should be counseled for the risk of recurrence and de novo stress urinary incontinence. So it is recommended that symptomatic urethral diverticula should be completely surgically removed. Now we will discuss the men with stress urinary incontinence. The treatment options, surgical treatment options include the bulking agents, fixed male sling, adjustable slings, and the compression devices. Bulking agents in men includes the injection of bulking agent has been used to try and improve the coaptation of damaged sphincter zone. Initial reports showed limited efficacy in treating incontinence following radical prostatectomy. There is no evidence that bulking agents cure post-prostatectomy incontinence. There is weak evidence that bulking agents can offer temporary short-term improvement in quality of life in men with urinary incontinence. There is no evidence that one bulking agent is superior to another. Fixed male sling. In addition to external compression devices, bulking agent slings have been introduced to treat post-prostatectomy incontinence. The fixed slings are positioned under the urethra and fixed by the retropubic or transobstetric approach. The tension is adjusted during the surgery and cannot be readjusted post-operatively. For the restoration of continence by these male slings, two concepts are now being proposed: continence restoration by urethral compression, continence restoration by reposition of bulb of urethra. In principle, the artificial urinary sphincter can be used for all degrees of post-prostatectomy incontinence, while male slings are advocated for mild to moderate urinary incontinence. However, the definition of mild to moderate urinary incontinence are not clear. The definition of cure used in most studies was no pad use or one security pad per 24 hours. There is limited short-term evidence that fixed male slings cure or improve post-prostatectomy incontinence patients with mild to moderate incontinence. There is no evidence that the intraoperative placement of an autologous sling during robotic-assisted radical prostatectomy return of continence after 6 months. Men with severe incontinence, previous radiotherapy or urethral stricture surgery may have less benefit from fixed male slings. There is no evidence that one type of male sling is better than another. Adjustable male slings. Adjustability in male sling surgery tends to adjust the tension of the sling post-operatively. Three main types have been used in men. One of one of these is Atmos system, then other Argus system, and the remix system. In the remix system, and all these have a mesh and a cross-section thread, and very tensor and the manipulator, which can be manipulated post-operatively. And in this we can see that a mesh is placed behind the urethra, and the sling is the traction threads are just pulled out of the body wall, and the manipulator is used post-operatively. There is limited evidence that adjustable male slings can cure or improve stress urinary incontinence in men. And there is limited evidence that early explantation rates are high. There is no evidence that adjustability offers additional benefit over other types of slings. Compression devices in male. External compression devices can be divided into two types, circumferential and non-circumferential. Compression of the urethral lumen, the artificial urinary sphincter, is the standard treatment for moderate to severe male stress urinary incontinence. Men considering insertion of an artificial urinary sphincter should understand that if the ability of an individual to operate the pump is uncertain, it may not be appropriate to implant an artificial urinary sphincter. There are several recognized complications of artificial urinary sphincter implantation, which includes mechanical dysfunction, urethral constriction by fibrous tissue, erosion, and infection. The non-circumferential compression devices consist of two balloons placed close to vesico-urethral anastomotic site. The balloons can be filled and their volume can be adjusted post-operatively through an intrascrotal port. Men who develop cognitive impairment or lose manual dexterity will have difficulty operating an artificial urinary sphincter.
So please go back to the diagram which was showing the sling. Yes, this one. So if you understand what the artificial sphincter is, there is a device which is either circumferentially compressing the bladder neck, or non-circumferentially. The controlling mechanism is actually a balloon, or say an inflatable sort of a thing, which is there in this scrotum. So in the scrotum, which is shown here in this diagram, the controlling device is just like a ball, and when you squeeze that ball, the device or the artificial sphincter is activated in the sense that it becomes it compresses the urethra. So this is all that has to be understood, but there are again a different kind of different components of the artificial urinary sphincter. So they have to be placed in such a fashion that they work to compress the urethra, either wholly, circumferentially, or just from the sides. But the controlling mechanism is in the scrotum. So that has to be understood. Yes, please.
There is evidence that primary artificial urinary sphincter implantation is effective for cure of stress urinary incontinence in men. Long-term failure rates of artificial urinary sphincter is high, although device replacement can be performed. There are conflicting data on whether previous pelvic radiotherapy affects the outcome of artificial urinary sphincter implantation. The usefulness of tandem cuff placement is uncertain. There is insufficient evidence to state whether one surgical approach for cuff placement is superior to another. Very limited short-term evidence suggests that the non-circumferential compression devices such as PROVAC is effective for the treatment of post-prostatectomy stress urinary incontinence. The non-circumferential compression device is associated with a higher failure and complication rate leading to recurrent explantation. The rate of explantation for artificial urinary sphincter because of infection or erosion remains high, and up to be 24% in some studies. Mechanical failure is common with stress with artificial urinary sphincter. Revision and reimplantation of artificial urinary sphincter is possible after previous explantation or for mechanical failure. So the recommendation include the offer duloxetine only to hasten recovery of incontinence after prostate surgery, but inform the patient about the possible adverse events and its use is off-label for this indication in most European countries. Only offer bulking agents to men with mild post-prostatectomy incontinence who desire temporary relief of incontinence symptoms. Do not offer bulking agents to men with severe post-prostatectomy incontinence. Offer fixed fillings to men with mild to moderate post-prostatectomy incontinence. Warn men that severe incontinence prior pelvic radiotherapy or uteral stricture surgery may worsen the outcome of fixed male sling surgery. Offer artificial urinary sphincter to men with moderate to severe post-prostatectomy incontinence. Implantation of artificial urinary sphincter or compression device for men should only be offered in expert centers. When men receiving artificial sphincter or compression devices, that although cure can be achieved, even in expert center there is risk of complication, which includes mechanical failure and need for explantation. Do not offer non-circumferential compression device to men who have had pelvic radiotherapy. Surgical interventions for refractory detrusor-overactivity. The options include botulinum toxin intravasically, sacral nerve stimulation, augmentation cystoplasty, and detrusor myectomy, that is bladder auto augmentation and bladder diversion. Surgical intervention for refractory detrusor-overactivity. Botulinum toxin A, and that is 100 unit dissolved in 10 ml of saline and injected in 20 points of bladder wall above the tribone. And the dose should be 0.5 ml per injection site. Is licensed in Europe to treat overactive bladder with persistent or refractory urinary incontinence in adults of both genders. So can we just listen to Azan and start?
Yes.
I think it's going on.
Yes.
Surgeon must realize that other doses of A and other formulations of botulinum toxin A, such as botulinum toxin A and botulinum toxin A, are not licensed for use in urinary incontinence. Summary of evidence for botulinum A toxin injections includes a single treatment session of toxin injected in the water was more effective than placebo at curing and improving urinary incontinence and quality of life. There is no evidence that repeated injections of toxin A have reduced efficacy. There is a high risk of increased post-void residue when injecting elderly frail patients. The risk of bacteriuria after botulinum toxin A injection is high, but the clinical significance of this remains uncertain. Botulinum toxin A is superior to sulfenacin for cure of urge incontinence, but rates of improvement were equivalent.
So can anybody of you tell me what is the mode of action of botulinum toxin or Botox, since it is being used in cosmetics as well as in bladder hypersensitivity? So what's the analogy, similarity? Anybody? No. So basically, it's a neurotoxin, and what it does is it sort of blocks the acetylcholine to act. So any neurotransmitter released from the synapse, from the nerve endings, is actually not there. So it sort of it is toxic to those nerve endings. So on a side, like for instance, when you have got wrinkles and you want to have Botox injection, so what it does, it is not a filler. It sort of paralyzes the muscle, and since it paralyzes the muscle, so the wrinkle actually is flattened. So what you have is a mask face. It's a face without any activity of the muscle. So basically, the facial muscles are paralyzed because of botulinum toxin or Botox. The same thing happens in the bladder. If the bladder is hyperactive, for instance, so if you want to, conditions like overactive bladder syndrome (OAB), then botulinum toxin, when injected supratrigonally, will actually cause the detrusor muscle to go into inactivity. So when it goes into inactivity, then you won't have spasms or for instance, the reflection of a spasm is you have to go to the toilet again and again. So the frequency of micturition is actually reduced. So this is the similarity of action of Botox. But it is not, I haven't seen it used in our center, and probably it is too costly, and there are things available which can be done beyond Botox. Yes, please.
So the recommendation offered bladder wall injection of botulinum toxin A to patient with urinary incontinence refractory to conservative therapy, and warn patients of limited duration of response, risk of UTI, and possible prolonged need to self-catheterize. Ensure that they are willing and able to do so.
Right, and my take on this subject is, if for instance somehow we develop our understanding of the pelvic floor muscle activity, and if all urologists who are actually concerned with this kind of problem and dealing with these kind of patients, if they understand this whole mechanism of contribution of pelvic floor muscle in various ways to this symptom complex and urodynamics, then we can ask our colleagues from physiotherapy to guide us and devise a strategy for muscle training, because that is not the domain of a urologist. But again, the leading role has to be played by a urologist. So it's the urologist who has to convince the physiotherapist to devise a strategy. The physiotherapist cannot do it on his or her own. You see, the guiding person or the person who is actually captaining the whole process is the urologist. So you are the one who send your patient to the physiotherapist and ask him or her to do something for you and for the patient. Unless and until you are convinced yourself, you cannot make use of physiotherapy or physiotherapist for that purpose. And if you can see the first line, it says that even if you have got, if you don't have got botulinum toxin, if you have got a pelvic floor muscle training program and judicious use of other drugs, it can be as strong as having a botulinum toxin. So there is a place for all of us to put our heads together, do something for these people, and we can we can have something which is cost effective, and that is pelvic floor training. Yes, please.
Right. The second treatment option is sacral nerve stimulation. And it is a two-stage implantation. In the first stage, an electrode is placed percutaneously under fluoroscopic control in the sacral foramen alongside a sacral nerve, usually S3. In your earlier techniques, a temporary wire electrode was used. Most recently, a permanent aligned electrode has been used for a longer test phase. Candidates who fail for full implantation are those in which the selected symptoms of urinary incontinence are reduced by more than 50% during the test phase. Sacral nerve neuromodulation is more effective than continuation of failed conservative treatment for cure of urge incontinence, but no sham controls have been used. Sacral nerve neuromodulation is more effective than onabashlan A taxon 200 unit injection at 6 months. In those patients who have been implanted long-term, that is 50% improvement of urinary incontinence, as urinary incontinence is maintained in at least 50% of patients and 15% remain cured. The use of entire permanent electrodes in a staged approach results in more patients receiving a final implant than occurs with temporary test stimulation. So the recommendations are offer sacral nerve modulation to patients who have urge urinary incontinence refractory to anti-muscarinic therapy. Cystoplasty
just a minute. You go back to the previous slide and the previous one. Right. So I just want to share with you one of my dreams, and the dream was it was a dream which was actually conceived by myself again in the mid 1990s, and it was something called nerve stimulation. Nerve stimulation for the purpose of urination, for those people who have been through accidents and they are paralyzed to an extent. Then since the upper motor neuron lesion has been there, for instance Brown-Sequard syndrome, so lower centers are without any control from the higher centers, and the bladder becomes spastic. It becomes spastic, and over time it becomes low compliance. So the person has to go to the toilet again and again, and then the person becomes totally incontinent, and it's a misery. The person otherwise becomes a normal person, rehabilitated, probably maybe the person can move along not with his own legs or her own legs, but rather on a wheelchair. But for the purpose of urination, there is a solution to the problem, and the solution is in your slide and in your explanation. One thing is missing, and that thing is for neuromodulation to happen and for placement of artificial sensors or stimulators, you have to have first done through sacral rhizotomy, which means that you have to cut through the sensory nerves at the level of somewhere at the posterior root ganglion. Now, if that is not done, you cannot do neuromodulation. So for sacral nerve neuromodulation and sacral nerve neurostimulation, first you have to pass through one stage, and that stage is sacral rhizotomy. So if anybody of you is interested, then we can talk about this subject somewhere else also. But that is something which is the ultimate of this field, and that is controlling the bladder function on say on our own hand, within our reach and with our own hands. So a person, you cannot imagine a person who has lost all control over the bladder as well as the rectum and becomes totally inefficient or totally at a loss of controlling these two mechanisms, that is fecal defecation as well as proper urination. And these things, two things, can be restored very easily if we have got this kind of neuro modulation in our hands. So first step is to do sacral rhizotomy, and the second step is to provide something which is like a permanent artificial electrode at the level of the sacral micturition center, so that when we stimulate those centers, the bladder starts functioning in the normal way. So this is the kind of situation that is possible, and there are centers in the world, I can tell you, who are doing it to a standard that there is no problem, and they have got a lot of different people coming to them, and these are the people who have been through devastating accidents, car turned over, maybe bikes or things like that. So this is a very interesting field of medicine, urology. Yes, please.
Now we'll discuss the cystoplasty and urinary diversion. The augmentation cystoplasty, also known as clam cystoplasty, a detubularized segment of bowel is inserted into the bivalve bladder wall. The distal ileum is the bowel segment most often used, but any bowel segment can be used if it has the appropriate mesenteric health. One study did not find any difference between bivalving the bladder in the sagittal or coronal plane. The procedure can be done with equal success by both open and robotic techniques, although robotic consumes considerably more operative time. This is the augmentation cystoplasty. In this, we can see the bowel segment has been taken and it is detubularized, and the new bladder wall is formed just with this segment of the bowel, and the bivalve bladder is augmented with the this urinary part of the colon part.
This is small intestine. Small intestine. Most probably we take.
Yes, I.
Yes. So most probably we take small intestine because we have got 20 feet of small intestine available to us, and the main thing, you can take any segment of the small intestine, but the prerequisite is to have a vessel in the mesentery that has got good supply, good arcuate vessels that supply the wall of that segment. So if there is no pulsating artery in the middle, in the mesentery, then this segment would actually be of no value. So you have to have a good supply, and that can easily be done. It's not a problem. It looks a very difficult procedure, but when you do it, you will enjoy doing it. So that's my impression of the whole process.
And the complications of bladder augmentation are further classified into short-term complications and long-term complications. The short-term includes bowel obstruction up to 2% in patients, infection 1 to 1.5%, thromboembolism and bleeding and fistula to 1 and less than 1%. Long-term complications include clean intermittent self-catheterization up to 38%, urinary tract infection 70% asymptomatic and 20% symptomatic patients. Urinary tracts and stones up to 13%, metabolic disturbance up to 16%, deterioration in renal function in 2%, and bladder perforation less than 1%, and change in bowel symptoms up to 25% of patients. myectomy or bladder auto-augmentation. Detrusor myectomy aims to increase bladder capacity and reduce storage pressures by increasing excising a portion of the detrusor muscle to create a bladder mucosal bulge or pseudo-diverticulum. It was initially described as an alternative to bladder augmentation in adult patients with idiopathic or neurogenic bladder dysfunction. But it demonstrated poor long-term results caused by fibrosis of the pseudo-diverticulum. This technique is rarely ever used nowadays. Urinary diversion. It remains a reconstructive option for patients with intractable incontinence after multiple pelvic procedures, radiotherapy, or pelvic pathology leading to irreversible sphincteric incompetence or fistula formation. The patients may be offered irreversible urinary diversion surgery. Some of the it includes ileal conduit, urinary diversion, orthotopic neurobladder, heterotopic neurobladder. And in this picture we can see the ileal conduit in which the ureters are placed into a small piece of bowl which is used to carry the urine, and the urostomy is made in the abdominal wall, and it is the urine is collected in the back, strong bag. And the orthotopic bladder, orthotopic new bladder, it is it means that there is a new bladder in the same place. As our orthotopic new bladder is substitute or a new bladder that is placed in the same location as the old bladder. And the procedure is done as the new bladder is made with loops of the intestine. Firstly, the surgeon removes a section of the intestine, then he reconnects the bowel, so there is no changes in bowel function. The piece of the intestine that was removed is cut open and to create a flat piece instead of a hollow tube. And the flat piece of intestine is strained together to form a pouch. The uterus kidney tubes are connected to one end of this pouch. The other end of the pouch is connected to the urethra. Urine will drain from the kidneys through the ureters and into the new bladder. The new bladder will store the urine and the individual will void through normal channels. There is the summary of the evidence. There is limited evidence on the effectiveness of augmentation, cystoplasty, and urinary diversion in treatment of idiopathic detrusor-overactivity. Augmentation, cystoplasty, and urinary diversions are associated with high risk of short-term and long-term severe complications. The need to perform clean intermittent self-catheterization following augmentation cystoplasty is very common. There is no evidence comparing the efficacy or adverse effects of augmentation cystoplasty with urinary diversion. Detrusor myectomy is ineffective in adults with urinary incontinence. So the recommendations are offer augmentation cystoplasty to patients with urinary incontinence who have failed all other treatment options. Inform patients undergoing augmentation cystoplasty of the high risk of having to perform clean intermittent self-catheterization and that they need lifelong surveillance. Do not offer detrusor myectomy as a treatment for urinary incontinence. Only offer urinary diversion to patients who have failed less invasive therapies for the treatment of urinary incontinence and who will accept a stoma and have been warned about the possible small risk of pregnancy. Surgery in patients with mixed urinary incontinence. Women with mixed urinary incontinence are less likely to be cured of their urge incontinence by stress urinary incontinence surgery than women with stress urinary incontinence alone. The response of pre-existing urgency symptoms to stress urinary incontinence surgery is unpredictable. So the recommendations are treat the most bothersome symptoms first in patient with mixed urinary incontinence. Warn women that surgery of mixed urinary incontinence is less likely to be successful than surgery for stress urinary incontinence alone. Inform women with mixed urinary incontinence that one single treatment may not cure urinary incontinence. It may be necessary to treat the components of the incontinence problem as well as the most bothersome symptoms. Surgery for urinary incontinence in elderly. Older women benefit from surgical treatment for incontinence. The risk for failure from surgical repair of stress urinary incontinence or of suffering adverse events appears to increase with age. There is no evidence that any surgical procedure has greater efficacy or safety in older women than another procedure. So it is recommended that inform older women with urinary incontinence about the increased risk associated with surgery, including on about AA injection, together with urinary together with lower probability of benefit. These are the flowcharts which will summarize the two presentations done today. The management treatment of women presenting with urinary incontinence. And first it starts with the history and physical examination. It is strongly recommended to have good initial assessment through history, physical examination, a questionnaire and providing diary, urine analysis and post-void residual volume and pad test. And then we will ask for such as specific symptoms such as hematuria, pain, recurrent UTI, and the prolapse, previous pelvic therapy, previous surgery by urinary incontinence, and mass in the pelvic and suspicion of fistula. These all things are asked and examined and ruled out in examination. If they are present, the further specialist review is recommended. After initial history and examination, and the patient is categorized into three. Patient advised to have pelvic floor muscle training as the initial first management. And the patient is categorized on the three incontinences such as stress incontinence, mixed incontinence, urinary urge incontinence. And again, the comorbidities are treated, and fluid intake is advised lesser, and the bowel functions and the drugs are reconsidered. Advise loss of weight, offer pads and other containment devices if needed. Offer timed or prompt providing adult and care dependent patient. If there is stress dominance, then we have to move further on. And if it fails, then again further drug therapy is recommended. If urgency is predominant in mixed incontinence, then start with anti-muscarinic. It is strongly recommended, or mirabagon. And consider percutaneous TPL nerve stimulation.
Now, just a minute. If you go back, what I want to do is to maybe step number 4 has to be done afterwards. For instance, this individualized behavioral physical therapy, including pelvic muscle training, should be done after you have classified at least in 3 different groups: stress, mix, or urgency incontinence. Why I am telling you is For instance, if you have got a patient with urge incontinence, and if you do pelvic floor muscle training, then it would rather impair urgency, uh, and it will not cure the problem, because urgency can be cured very easily, or sometimes easily, with other physical therapies and probably with certain drugs. It will not affect if we do something called pelvic floor muscle training. So if you put this bar afterwards, then it's all okay for myself. Uh, I want to differ from this flow chart a little, managing my patients.
Okay.
I mean, this is open to argument. Somebody can argue on this, but my gut feeling is it has to be done one step after you have
So you
classified.
want to say it will mask the further treatment?
Yes, because you see, the basic mechanism behind stress incontinence is you have got a loss of those effects of anatomy, which actually makes a person continent. Probably it's the angle of urethra with the bladder, or probably it's the pelvic floor muscle that makes the person stressed and stress incontinent. But on the other hand, the urge incontinence is because of the reason that there is some problem with the detrusor muscle activity. See, these are two different aspects of maybe the same reflection, that is incontinence, but these are two different groups. So you cannot have pelvic floor training for both. On one hand, it can affect one positively, on the other, it can affect one negatively. That is my take on it.
Okay. If the initial treatment and the antimuscarinic have failed, then we offer urodynamic studies. If findings may change and change further treatment. And for stress incontinence, treatment options include advanced treatment option includes mid-urethral sling, and vaginal sling, Colposuspension, and urethral bulking agents. And if these all again fail, then the patient is into next category, which is complicated, and the second line surgeries are considered. In the mixed incontinence, if the stress predominant, treat as stress incontinence. If urgency predominant, and then the treatment options are botulinum toxin and sector nerve stimulation. And if both they fail, then we can go for bladder augmentation or urinary diversion. And in urge and incontinence, the same treatment options are such as botulinum toxin and nerve stimulation, and later on bladder augmentation or urinary diversion. These are the last treatment options. And this is the flowchart for treatment of men presenting with urinary incontinence. Again, it starts with initial assessment, which includes the physical history and physical examination, and questionnaire, dividing diary, urine analysis, and post-void residual urine, and the pad test. Again, look for these symptoms and examination findings such as hematuria, pain, recurrent UTI, previous pelvic radiotherapy, abdominal DRE, and finding of suspicious of voiding dysfunction. And after that, the patient is categorized into stress, mix, and urinary urge incontinence. And advice is given for bowel function and reconstituting of drugs and comorbidity and fluid intake. And patient advised to have to lose weight and opt for pads and other containment devices if needed. Offer timed or prompt for avoiding infertility and care dependent patient. And if the urge incontinence, the anti-muscarinic agent and media background is advised. In mixed incontinence, the predominance is first determined. If stress, then further direct therapy is advised. In urgency, then we start with anti-muscarinic agents. Consider urodynamics and lower urinary tract assessment in male. It is strongly recommended, and it helps to further diagnose and categorize the patient. If in stress incontinence, offer fixed slings or artificial urinary sphincter in men with post-prostatectomy incontinence. And in mixed incontinence, again the predominance is determined. And if it is stress incontinence, then it is treated same as stress incontinence. And in urge incontinence, and the predominance of urge incontinence and mixed incontinence is treated with injection of botulinum and second nerve stimulation. And the further and the last option remains with bladder augmentation and urinary diversion.
Thank you very much. So it was very interesting. I think it's a very comprehensive kind of session today, both male and female, right from conservative therapy to pharmacology and then to surgical therapy of incontinence was discussed. So I myself have gained a lot from these two presentations. So thank you very much, both the presenters. If anybody wants to say anything at this point.
So there was written there is a associated risk of malignancy with stoma formation.
Yes. Actually, it is not the stoma that is mostly involved. When you do, for instance, it depends upon the kind of surgery that you do. For incontinence, normally there is nothing called cystectomy and diversion when you have got an evidence of maybe a positive or negative surgical margin of the ureters which you have dissected or rather transected from the bladder for the purpose of urinary diversion. There they have this incidence of malignancy at the uretero-ileal junction of the ileal conduit, because that might be the area which have got the ability to turn into the same kind of malignancy that the bladder had, which was taken out earlier. In this case, what happens is in incontinence, normally the surface of or mucosal surface of the intestine is not something which is exposed to the acidic pH of urine. But when you do ileal conduit, for instance, or some new bladder formation, then it is the absorptive surface, the mucosal surface of the intestine, which is exposed to urine having a pH of less than 7, maybe 6.5 or 5.5, and that pH, which is acidic in nature, leads to something called maybe dysplasia, which can move on to metaplasia and neoplasia. So that might be the kind of transition from normality to malignancy. So that is one thing. But the second most important thing, which I think it was mentioned, or it was I'm not sure whether I picked up or not, is when you do something called new bladder formation and use of intestine for the purpose of conduit, then there is another thing which is known as metabolic disturbance, and that metabolic disturbance is more important as compared to malignancy, and it happens in patients according to their GFR status preoperative. So if a GFR status preoperatively is already of compromise, then again it will not only remain compromised in the post-operative period, but it can deteriorate, and when it deteriorates, it leads to a lot of problems. So you not only have to provide a new bladder for the purpose of incontinence if you are doing surgery in that direction for that purpose, but you also have to provide something called evacuation of urine. Either it is manually evacuated by means of a Metrofenoff channel, you put in a catheter every maybe 3 hours, and you empty the bladder, or you do something for the evacuation. Otherwise, if you allow this urine to be in contact with the absorptive mucosal surface of an intestine, then it will be absorbed. It will be absorbed and it will remain in circulation, compounding the uremic condition if at all it is there, and the person has got a lot of metabolic load to carry, right? So it is rather unfair for a person who is having compromised renal function to start with, and you provide such a procedure, right? So I think yes, Rafe, you want to say?
Sir, just one clarification about the urethral diverticle. Is this condition gender specific? As we discussed it, that they are present in women. Do we see it in men as well?
Yes. I mean, in men it is seen more common as compared to female, because the female urethra is very short. It is like 4 centimeter in length. But that is a thing which has to be at the back of the mind of any person who deals with lower urinary tract and lower urinary tract infection, perhaps. So if there is a repeated infection, recurrent infection, then perhaps the glands of litter and all these glands which are periurethral glands, they are, when infected, they lead to a lot of infection in the urethra in both the gender, and they can lead to maybe abscess formation, and this kind of problem, which is a diverticulum, is actually something which leads to abscess formation and recurrent infection. So this is the way that the whole pathology goes, right? So we'll meet again tomorrow. Thank you very much for today.